So thanks a lot to you for being present for this third roundtable, I wish will keep you awake and alert. It's try in 50 minutes with such brilliant speakers. We're going to unveil to you how to fight back resistance to change. So it's an illusion, of course. We all agree. But in the end, to start off, how to fight back resistance to change, let's start talking about resistance to change. Ideally, talking about it at another time than at the end of the day and out of the bar, let's say, the bar counter. So it's 11. We still have a lot of energy. I would like to start with a little historical parallel. In a domain that's not so far off from health, it's the military. Napoleon Bonaparte revolutionized the art of war. He was, at the start, his Grande Armée was inferior in numbers and in weapons and soldiers. Yet the Grande Armée is going to go victory after victory, and it starts the Italy campaign, which is the foundation moment in the series of battles and victories. How does he do with less means, less manpower, and without ChatGPT? Because we spoke a lot about it. How did he do? It's the main idea, the key idea is mobility. It's mobility. Mobility in the organization. The army was faced with the small units, can be dispersed and quickly gathered to face a common objective. Mobility in the logistics and the supply chain. In short circuits, as we said, and the supply lines. It allows you to move fast and surprise the adversary. The third element is strategy. Strategy is clear, but it's all adaptable to circumstances. And so, thanks to these three elements, we're going to see, in spite of weaker numbers in the first battles, we're going to see victories emerge. It's an element on which I wish to get back to. He'd like to say that it's in the French character to exaggerate, to complain, and to change everything as soon as you're disgruntled and unhappy. And this is it's still very strong and vivid. And because so resistance to change can kill. It kills creativity, envy, energy, but also let's not forget it kills the patience. So we're going to have to call evil where it is. So name and shame to move forward. So it's a civic duty to do that, because otherwise the risk is excessive politeness, being afraid of being called out if you do wrong. So we have to free up speech and understand and move forward. And if that would be the matrix that would allow us to get out of to fight resistance to change. So let's open your chakra. Let's breathe in and let's get to it. I'm going to start with a very simple question, and I expect a short answer. I'm going to start to my left here with you. What is the main cause of resistance to change in health? I think we saw it yesterday in debates. In resistance to change, not just in health, it's fear. It's doing things for the wrong reasons. It's the politics in the wrong sense of the term. Wrong. I like to share with my teams, when you don't feel something deep inside in your gut, you're not a leader. That's what you said. You have a leader. So resistance to change in health, I agree, is no shared vision, no strategy. It's not real exchange. We exchange a lot. Everyone has their position. We saw it this morning. There's no consensus, no co-construction. We fake to get together. It plays well. We saw it this morning. A little tap on medication. And if we would all be just the sole responsible of everything happening and no communication. So we forget the patient in the end, and we forget the future patient. I would like a point that we saw yesterday. We have two issues, and we try we have patients, we have care, and we have the future patient and prevention. Because yes, let's not break everything, let's not throw everything out the window, but we still have a health system that's starting from the World War II, and we're not at World War II times anymore. So it would be a little less rich and dense. I think something the absence of pluriannual vision, long-term vision, on which we're going to get back to. Everybody has a future vision. The fact that we have a vision, pluriannual, like everyone does in their personal life on what we're going to do, a little further off than Christmas, I think something important in the industry, and organizations of our hospital structures, whether they're public or private, or whatever free exercise activity. I think it's something important. We have to know where we come from to know better where we're going to. I not agree really. I'm very happy to keep these foundations of the post-war. What made our current society? These were foundations, post-war foundations, on the Council of the Resistance, are great foundations on education, on security, and access to our social safety net. We all have to be aware to take care of it. We have to preserve it, because sometimes it was said, it's a very beautiful sentence, the social system of some is the only wealth of those who have nothing. So let's be careful on this first point. I think this vision, this pluriannual vision, multi-annual vision, I don't know what the word that matches the best what I wish to say, because I haven't found it. We need some flexibility and fungibility between sanitary, social, medical, because we see well that everything is intertwined. And all this should allow for hospital structures to better organize the home care and to better organize the cities. So this fungibility and efficiency of professional practice on the territory is the vision of Napoleon. So sometimes we need small units, small primary care units on the territory. Let's define what's the territory first, but this, without big coordination with health professionals can speak to each other, without megastructure needed that will avoid resorting to the hospital and treating people in hospitals. It's also organization of the territory and the attractivity of the territory. Thank you, Yannick. Laurence. So when I was suggested to reflect on this question, what makes us overcome resistance to change? I was thinking this summer. We were all enthused by Olympic and Paralympic Games, and what made us live together was this 4 gold medals of Léo Marchand, and we were all standing up and happy to be together, except Léo Marchand. There's something that he works is to be in his lane. It's very useful when you're Léo Marchand. We're around the table, public, private, different path. I would like, when we have suggestions to make to you, we can speak about them to get out of your own lane. I'm going to speak about health institutions. To know where to go, it's not complicated. We have the health authority, the INCA, that gives us a roadmap. It's not a topic of where we have to go. But why don't we go faster? And maybe we have something to dig deeper into. The first point, the alpha and omega, to which we get back to the hospital, is how do we find the little nudge to take on the whole team along. And so what is the nudge that works very well in the hospital and that makes sense? And it goes back to what Antoine said yesterday, the topic of the quality of care. And then we start having a project, and then there's the management culture that allows us to take the teams along. So regarding this topic of maybe we don't have a vision given to us by the ministries or a succession of ministers, I don't think that's an issue. It's not disturbing so much. We know where to go. We're free, in a way. And now we have to take power and to launch project, and nothing prevents us from doing so. Today, we don't expect big funding reforms. We need what we need to management culture, and to put this nudge on the quality of care. And we're so banzai. Let's go, Lionel. First, when I saw the title, it says that really sounds like Guy Valenciennes, How to Fight Resistance to Change, and I couldn't help remember this Edgar Faure sentence: "Resistance to change is is marching and there's nothing to stop it. So let's make another comparison. I think that the title is excessive. We don't talk about people who are handicapped, but disabled people in disabled situation. So from our health authority view, we have three big domains: assessment of health products, recommendations of good practices, and assessment and certification of institutions. If I look assessment of health products, precocious evaluation assessment is a success. From industrials, 288 demands treated, requests treated by the High Health Authority in a term of 79 days, so not less than the 90 days planned. And if you look at medical devices, there's also a precocious assessment, and we have 13 demands that have been treated. And so it bears the question, does there's not so much innovation? Or do we consider that the model applied to medical devices by the legislature and the regulation is not the most adapted, adjusted model? Or somewhere there's some breaks, some obstacles put by industrials to the value assessment prepared by the health authority. So that's a source of resistance to change. So third point is the revision of the regulation on medical acts. So there's some acts which are obsolete and new ones have emerged. And so why have we expected since 2005 to revise apart from the workload, and François Richard knows it's considerable. And I think it's been very well anticipated. And so the referential of innovative acts, medical acts, out of the nomenclature. And so for the flow of new demands, we have to absorb the former demands, the old demands. It's 900 clinical situations and 130 acts. What is the duration we have? What is the timeline we have? We cannot do it with extra means available. So at some point, there are means that we haven't planned for. One thing on the assessment of health institutions. There's 4% of non-certified in our countries. So in 96% of the cases, they're certified, accredited. It shows the quality. I would like to be sure of the consequences of what we say behind on these non-accredited institutions or under conditions, and those who are certified with high marks, and maybe we need to put boosts for those who have this high quality. And then there's our work on recommendations of practices. On these recommendations, it's good. They're of great quality, but are they implemented? Today, is the DPC is interested systematically to update the knowledge founded on recommendation of this assessment. And that's a point on which we have moved forward with the DPC structures. The audit court has a great report on that, which suggests the suppression of the triennial of the DPC if there's accreditation from the professionals. But it's a real issue of the impact. It would be logic that the authorities would ensure that after recommendation they are in the training programs of lifelong training. Thank you, Lionel. Dominique? I'm new here at the CHAM, so I'm trying to innovate and start answering with music. I hope you can hear that.
Qu'est-ce que c'est? C'est un quiz. On est aux Jeux Olympiques. On a vibré, on l'a rappelé aux Jeux Olympiques grâce à la musique. C'est pas les Champs-Élysées, c'est pas David Guetta, c'est quoi? L'apprenti sorcier de Paul Dukas, poème symphonique.
C'est Paul Dukas, Fantasia. From Walt Disney. And so what illustrates in the introduction, in the first roundtable, what illustrates this symphonic poem is doubt, fear. As Laurence said in the intro, what is this resistance to change? And I have a double hat to claim it rather than assert it. I represent companies, French companies, under the MEDEF hat, and to accompany these companies in my professional practice. And so I realized that after 30 years in practice with these companies, or to represent them, we never got out collectively of a fear that's linked to the crisis, so the mad cow disease in the 90s or the contaminated blood in the 80s. In any case, resistance to change kills, but yet companies, health companies, are called to make live, to save, to care, to accompany the populations, even to win medals. Thank you to Snitem to work Paralympics, to win Paralympic medals this summer. I tried to innovate in my introduction. We overcome resistance to change thanks to these health solutions that we provide to companies if we let them innovate. And I know that we'll have debates with Lionel because he attacked strongly. I'm going to answer, as long as we have this precaution principle unconsciously before principle of innovation, we'll still always be last in line. Our companies will continue to grow on export and not on French territories with French patients. So we have a long, interesting list. We have 33 minutes. I said short. You've been relatively long. Now I'm gonna much more punchy on your interventions. So working together. It was mentioned several times. What lacks? Why don't we do it? Who wants to go ahead? Just to go quickly on a point. Why this topic? I'm not. It's équivalentien because it's a diverse table. It's not diverse if we don't have patients. If we ask a patient if we think there's resistance to change, I think we know the answer. A lot of people spoke for patients. I think that's not the definition. It's true. And so regarding this issue of resistance to change and working together, we see that the elements you mentioned are issues of booking silos, segmentation. There's maybe a topic of culture and method. We have to accept that things take time, and that, I don't know, if we say that we review our practices in oncology, it takes 10 years, cancer by cancer, and accept that this time frame. And we should look at other countries where they carry out great reforms with structures, like in the Netherlands, when they merged the university part for the health and the hospital centers with big medical centers. It takes 13 years, but at the end they have something rather very massive. When they reviewed all the cancers, it's 10 years. You have to accept this time frame and accept to go not with the method, not the method, the Napoleon method of the Russian campaign where we tried to build a cathedral and we worked with a long front, but keeping the early stages of Napoleon or du Guesclin, village by village, segment by segment, to accept to go. We know we have 4 pathologies, heavy pathologies, the mental health, oncology, cardiometabolic disease, and neurodegenerative part. We take one segment and we accept to go segment by segment and to have proof of concept. To make errors, correct? Proof of concept one by one and to take time. So who's on? Who's we? Who's we? He said we. I suggest something. I'm going to tell a story. I come to the CHAM 10 years ago, first time, and then I did a few other things, and I came back a year ago. And when I came back a year ago, I said to myself, I see the same faces. We all got older, me first, and we're on the same topics, saying that we all do the job well, yet the figures are stubborn. Maybe we're going to get to 6% deficit. I represent companies for medication. We have the lowest price in Europe. Fiscality, which is taxes, are highest in Europe. Access, we can disagree on. We have topics on moving forward with innovation and precocious access, and it's a great initiative, and we can go further. The figures are stubborn. So either we stay here or we throw the ball at each other. And I think medication should be paid. We need caregivers, we need medication, we need hospitals, but a caregiver without medication, he can't do everything. If we continue to throw at each other the hot potatoes, it's not going to work. So we made a simple offer 8 days ago. We did a press conference, and what did we announce? That we said that we need to put a boost in the system, and that we are aware that public spending is drifting off, and that we can take our share of that because we have all a stake in the success of it. And we did something crazy. We're going to suggest to all, offer to all, to make 1.1 billion savings in the systems every year. 1.1 billion. It's a lot of money. And this 1.1 billion is without penalizing the patient, without penalizing the state and companies. It's win-win-win. 300 million, we spoke of it yesterday with one of our administrators. It's the good use of medication. It's good for patients. It's good for the economy. It's good for the ecology, the environment, and we have a pilot showing that it works. And we spoke earlier of it. Those pilot programs work, and we can then spread it. Second suggestion, today access to care is more complicated. We can delist a certain number of medications, not reimburse them anymore, but go straight to the pharmacy when you don't have access to your doctor. Today, a quarter of French people go to the ER knowing that they could have access to their medication, but they don't. So 300 million saved. We compared European level. There's no issue of public health and overconsumption. Let's go. We can do this pilot. And a third block, very important, is since our system is a bit complex, and let's not call this out. What we have to pay for the state takes 18 months to pay our taxes safeguard clause. Let's pay it right off the bat. We can save 500 million a year. Plus this is 1.1 billion. I'm going to go further. My 1.1 billion check can go up to 10 billion this year. 10 billion, 10%. So it's 10%. So it's to pay now, right off in cash flow, what the medication companies owe to the state. And I'm going to finish on this. It's provisioned in the accounts, but in cash flow in 2024 to pay right off the bat the 10 billion we have provisioned by the medication companies. They're ready to pay it right away. So possibly we have a check to write. We knocked on certain doors. It didn't take. We have 10 billion for you. I hope, Guy, that the conference is broadcast in the ministry, that we have all heard the ministry. There are billions, and apparently it isn't penalized everyone. So that's good news. I would like to go back to the we. You have this suggestion at the Professional Trade Association of medication companies. So you would like to get back on the we. I don't have the pretension to say who's, but I think that we have. Let's talk figures. So we're a few days. If we don't talk about this committee meeting. So let's look at a few figures. Let's read the figures. And so we have health insurance spending, and let's not play on figures, but 9 to 12 billion funding, and it's the Social Security budget. We have a branch that is that's on other topics, more political, and it's going to explode on the retirement aspect. And the same budget, and we need this global vision, societal vision. We cannot talk about spending, Social Security spending, or health insurance spending and health spending without looking into to link it to our collective point of view on pensions. A lot of this spending are structural spending, and we have a legislative framework, which is the finance bill project, which is a regulatory framework of a budget legislation, cannot give structural answers. And I disagree with you on 2 points. And the third point, maybe. On the first, you said we have time. I'm not sure we have time. We have funding laws, budget laws on Social Security. I'm not sure the tool is adapted to this current situation, because when we want to have a sector evolve, we want to favor hospital or hospitalization structure, public or private, it's an envelope that's going to diminish. And if we, on the city hospitalization, that we reduce, have a kind of a schizophrenic system. I think first point, we cannot all solve on budget bills. And to display annual budget law on health is another issue. Second point, I hear around the table this example of Laurence on the fact that we need to solve things at the territorial level, but we forget one thing. Whatever the authorities in place, we forgot to take care of the training of our different players. We train about the volume of doctors that we trained in 1970. I would like to say this figure. We all wander of medical deserts. We don't cover the needs in pensions for 3 reasons. We took 50 million inhabitants more. I have less historical knowledge than at our previous roundtable. 15 million people more, population that has aged out, that has multiple pathologies, and a relation to work that has completely changed. Because for one doctor going in retirement, we need 2.3 to replace him. So to go to war, we need fighters, combatants. So we need to delegate tasks. We need new professions. There's going to be innovation. There's going to be AI. But at one point, we're gonna need players to take care of this whole system. So if we don't, in this territorial atmosphere, to have efficiency of care, and I said it in the press already, I'm very afraid of cuts, because when you have cuts, you have a budget, an annual budget, and you match the needs of this annual budget, but you haven't solved any problems, prospective problem, any vision, annual vision. Everybody's unhappy, and you strain the system even more than in the previous year. So the last point that I disagree on, you said finally, this change of misuse is not so important. We have an objective and we pursue it. And I think on the contrary, we need at some point to be able to incarnate a vision, a structuration. The nature doesn't like the void, and so I have nothing against our central administration. On the contrary, and I measure as a general reporter of this law and to have all these players around health, and which is great to work with, and there's good foundations. But if we want to answer the needs of our populations, and if we don't have to emerge extremes, and that's the topic for 2027, we need a vision, a political vision that's not technocratic, not just a budget perspective, so that this meaning and this awareness and care of patients is better expressed. Maybe I'm going to be old school. Where there's a will, there's a path, and you need a political vision that incarnates that. I'm going to try to reconcile both, a little top-down and bottom-up. We need both. It will come from both. We need vision. We need to take these elements on the ground. Let's go back to the. I'm not going to let go of this. We talk about resistance to change. The list is long. A lot of issues. We heard more of them. Who do we put around the table? How do we move forward on these issues? As you said, it's been 10 years. 10 years ago, we were already here talking about the same stuff. We haven't moved forward. So why? Who's the pilot? Maybe you can see that it must be we. So we're all together. That would be a good start. And we start so again, we're faking it. We're in a little world among friends. We talk with our little vocabulary. If we put 50 patients that don't belong to, or Parisians or non-Parisians, they don't understand. So we agree on the topic. We need multi-annual vision. And that's one of the topics of our president on his first tour. That's what the Snitem is expecting. So let's stop faking it, and we need listening. Let's not to fake listening to each other, Mr. Collet. But we're still faking it. When we put the safeguard clause to copy it, because we know it for medical devices and medication had the same thing. We repeated that several times, and it's not working. Let's stop us collectively to waste time on things that don't make things move forward. So how do we put pluriannual, a multi-annual vision on innovation? If companies don't come, that means it's not working. Let's not look elsewhere. We had a first version, second version. The thing that we have to keep in place, and you said it, without medication, without medical devices, we can have conversation on increasing the salary of doctors. We cannot care just with that. So how do we do today? Today, companies are closing. Startups are funded first by the BPI, but they cannot find funding to put them on market. That's the reality. So let's listen to each other. Let's stop faking it, and let's ask ourselves the real question. When we don't try to convince our neighbor, whatever his job, carpenter, mason, what we try to reach, to strive for, we cannot move forward. We're going to continue to fight. I get back to my point. What do we really want to do in terms of health? And I'm convinced there's one thing: prevention and care. And I agree with you. In care, we're really good. We saved 15 years, not on prevention. Second solution, after the multi-annual perspective on solutions, companies, maybe Dominique can help do prevention. At GE Healthcare, we set up a prevention program on endometriosis. It favors diversity, it favors prevention, it favors unity, and maybe it's going to diminish work stops. So, bravo first. I'm happy that we shared the idea that we need a multi-annual vision. All the surveys we carry out with industrial, small, middle, big, international or national, we need to project ourselves in a multi-annual vision. If we have these results in 9 years, 9 years ago, we started the offer policy. The employment rate went up. It allows our companies to invest and to look in the long term and to take risks. Why can't we do this on the health system? So that's the first thing, multi-annual vision. And I'm happy that there's a representative of the nation that has this, is convinced of that. You can carry that, you bring that up to the highest levels. Where are the obstacles to this long-term vision? So I looked into studies that we carried out for the Snitem, and I looked into the innovation system. When a startup is growing, where does it stop and why, and where can it prosper? So we looked at the deal analysis, a company that emerged. They had an innovative health solution available. What is the success rates in France? But it's going to stagnate at some point. And when the deal operates, 50% of the deals they're sold to another European company. So it kind of goes away with the idea that it all go to the U.S. and the devil's in the details. Half of the deals happen in the U.S. and whether the deals is the biggest and the most important. And so we have a problem. We have the innovation system stagnates with a lot of subsidies, and the great deals go to the U.S. Why? Because we don't have a system, a unified capital platform at the French. But let's look further. Somebody said we need 50-year plan, not just French, but European pluriannual. The moonshot, as Kennedy said, if we want sovereignty and health security in Europe, you need this unified capital platform to steer innovation without indebting the state more. And so this unified platform capital, the second proposal is on, you need, as Laurence said, to put the patient at the heart of the system and have an integrated system revolving around it. We have talked during the studies about digital solutions, AI, by talking with representative of the Poste. Florence Dupré is around here. We went in depth into the topic. It's a solution and an issue, this digitization of health, because it leads to the issue of the fragmentation and some apps that's going to care the heart of my father's heart, the hypertension of my mom, the hyperactivity of my children. We're going to have fragmented solutions, but we need to organize an integrated system around the patient, revolving around the patient, because digital is not the panacea. It's not the silver bullet, and we have to unify the system more. And it's based on a study we did for the health fund, and we tried to compare the dental care in several European countries, in the Netherlands and Germany and France. At some point, health professionals, they're going to have to open up. Why do we have less dental problem in these countries? Because they do a lot of prevention. And two, it's not just dentists who do this prevention. It's a lot of other professions that are not under jobs that accompany patients and future patients. To this opening up to other professionals is a key element. So we're not going to be closed off in an old-fashioned model. So a lot of things are a lot of innovation. The market is not always following. There's a problem of silo. How do we react on this difficulty to have this dialogue? What's lacking? I think dialogue, I agree with, I think people are talking together, these things, how we move forward. Once we have, it seems more important to me. Our general reporter talked about, I agree with this multi-annual. I coordinated the industrials was mentioned that on the budget bill of 2016. We had this idea already in place. It's not just the private, it's our sectors, which is the public sector too. I would be glad to see on my budget lines on the 3 coming years and to have a budget ceiling clear in my mind. I would think we need to remind that if we want to reason in multi-annual and the vision, we need prospective tools in health. And we don't have available, contrary to the army or other sectors, of prospective tools. Those, some have it. The higher health authority has to deliver a prospective analysis on selected topics. We have to deliver that. I think Lisa has mentioned that on innovation. And we need to have a tool, a clear tool, heading local authorities to see what health is going to be about in 10, 20, 30-year term. Knowing that innovation, and we hope there's going to be breakthrough innovation, we need this tool. And maybe, what an issue. We talk about multi-annual vision, perspective tools. Aren't we adding a mess to the mess, or we're not adding layers here? These tools are really going to help. So with that, we're going to fight resistance to change. It's always the issue. We're not going to get back to the political current situation. That's why I said also it's not the budget bill project that's going to solve years of problems, and it's a budget bill that's at high risk. It arrives late, and the majority has never been so narrow. So the passage is going to be very short to overcome this. So with all these political difficulties, we see that we're going to have to change things. I'd like to bounce back on prevention. I think we need to be able in this country. We talk about cardiology. I'm a cardiologist. At some point, if we're not able, with all the players, and there's a lot of actors on the territory, biologists, pharmacists, who work on the land management and who cover the territory. If we don't have at 40, 50 years to be able to do a checkup, you have hypertension, you smoke, you have cholesterol, you have diabetes. That's what we do in any surgical activity to improve the success rate. With biotech, with standard biology, we can stratify. If we remove infarctus, strokes, and that's going to lead to pay for work stoppage, and the spouse who's impacted because at 4 years you have a stroke, you have children, it's daily allowances for the spouse, it's GDP impact, cost for the GDP, and the wealth of our system allows to maintain salary and income. But if we do the medical economic studies on this, we need to invest in prevention. We need to reap, to sow to reap. We need to be able to reap. And the problem is structural. we don't have this efficient margin in the budget to be able to invest accordingly on prevention. We need a clear plan. Every man and woman in France at this age has to benefit from a cardiovascular checkup. The same thing on oncology. Why do I say that? If you look at cardiovascular and oncology, it's a big part of long-term afflictions. So rather how to see how we can suppress budgets, we have a flow and stock issue. One of the common sense measures is to stop from people entering in ALD with pathologies, oncology and cardiovascular. So these prevention measures, all the players would agree to be able to do that, and we save money, we're less sick, players find meaning in what they do, and our health and social system is preserved. It's always income contribution that contributions that pay for pensions, and it's more productivity. But this virtuous circle, we need time, money to be able to do it, because the return on investment is going to be in how many years? Not right away. So therefore, the multi-annual vision. So the system is so constraining that I hope that the innovation will allow us to save some efficiency margin that we can put into prevention. And now we're trying to put circles into squares. And as you said, if all the players and we're going to save money. I think one of the issues I would like to know concretely, Arnaud, how do we and all players, how does it function in a hospital, university center? I'm a microscopic player on the territory. I'm not in the institution, and I don't represent an economic branch. I think we talk about a new techno layer and the pluriannual. We need it. We need continuity. We need to take time and accept it. Take time. I think this continuity, I share that completely. But it's supposed that we get back to the Fifth Republic. We have parliamentary stability that we don't have. Nothing prevents us from moving. And I think that really, and we see it a lot. I come from the hospital university center in Nancy, and I know we need to move forward, because otherwise we're not going to face the needs of the population. And we move because the roadmap is known. What Lionel reminded, there's a lot of things that are moving and shifting, and the roadmap, Dr. Lib and other things are moving. It's great, and I think we need to operate collectively. Places like here are conducive to that. And I don't think that, from my point of view as a microscopic player, we don't expect any reform. We just expect, on the contrary, that we focus on this implementation and this change in the territory with all the political consequences that we experienced, this inversion. And I would love that the regional health authority tells me, your objective is Meurthe-Moselle-Lorraine department, you have more detection of cancers of 10%. So KPIs, very precise on pathology, to have care, health objectives clearly. And once we, with or without budget, a little parenthesis, we don't have more money in our health system. Out of the therapeutic innovation, yes, we have an issue here, but we don't have non-cash. There's elements of repartition, distribution of funds, but I think we don't need money. We need to change mindset, and we have to build it. And now, and we means in Nancy, it's the player in this people, health authority, local authorities, social medical administrations, and we coordinate for health paths, and we have population responsibility project, and then we'll go to the ministry to see, look, we did that, and we improved care. And this is the logic that seems interesting to us, and I think that we don't understand enough. When we do a reform, we shift a lot of things everywhere, and we do reform on top of each other without understanding how things are shifting. And the tectonic is shifting. I think there's fine-tuning issues. And we have to stabilize a little bit the landscape, and we put health objectives back in the center, and we give clear health objectives. And we give me clear KPIs, plus 10% or plus 5%. And why doesn't anyone do that? Comes to you, here are your objectives. Here are your, why isn't that happening? Who has to give this objective? How do we define it? It's the high health authority? It's the regional health authority? Why are we in this environment? And you have this hospital, and we don't have performance. So oncology is very interesting because the INCA and everything we do with industrials, they write roadmaps. If I want to know what I need to do in oncology, I just look the decennial plans. I'm not. So at the National Cancer Institute, I'm in the previous step of giving support. So the roadmap, we know it. It's very clear on oncology. It's less structured or identified on neurodegenerative and other aspects. It's less structured here. But these are the topics we can work at the institutional level. And we have enough equipment, everything that companies and recommendations. The roadmap is rather clear. But then it's a question to align objectives. Thank you. Last point, Laurence, then we're going to have to finish off. We have 3 minutes left. And I would like to have one reflection on one topic after. I would like to trust our care system, our health system. We're building a Europe of defense, and we understand why. And now trying to protect ourselves against war, and we understand why. Urgently, we need to build a Europe of a strong Europe for health in France. And we get older, we need care. So invest in care, invest in innovation is important. And I think we need to stop to war, to fight against each other, because when we war, we count the dead. When we do peace, we're more powerful to face the challenges and a demand we have that can work. At the beginning of the year, we were invited, rightly so, to manage the shortage issue, and we were at the table. The shortage issue, we agreed to an action plan. We signed it. We signed the charter, 48 hours. We were here to do it, and we said it at the time, at the Minister, Lionel Rousseau. And it doesn't work, and we put steering tools, KPIs, and we do it every day. And we look, and we made progress. Progress is here, and let's offer solutions to give a boost. And around the table, we're only directors where we are. We have the means to act. Let's wait annual objectives, but now we have means to act right now, and we can make proposals to make the system move. We need to build a Europe of health and a strong France for health. We have less than 2 minutes left. I'll ask each one of you, what do we do? What is a priority so that in 5-10 years we don't find ourselves again to have the same debate in 10 years? What needs to change? Absolutely. The minister said there's no magic wand. We need courage. We need to work together. We need to make proposals. Let's stop faking it. We live in a world. We have plans, but there's always 1 out of 2 women who is not diagnosed of breast cancer. And that's the reality. My opinion is to maintain systems in place when we know that a great percentage of structures, health structures, are in deficit, whether they're public or private, or for old age homes. I think we need to be careful. We're on the edge of a cliff, and we can go further and further down if these structures continue resisting. So my priority would be to sanctuarize. It's maybe not enough, but a great number of structures. Otherwise, we're going to aggravate the health offer. I agree with the director of the Health University Hospital to have professionals working together, going on the territories, but let's be careful. We can lose a grasp of certain territories which cannot live on credit forever, and there's a danger. A lot of public actors do not pay their social contributions, so we're on the edge of a volcano. There's 4 of you. Let's trust each other. I think to have the text, to have figures before, not overnight. We are involved. We're not just suppliers. We're partners. So we need the text before so we can work on them. It's not for me to tell you. Arnaud, So public health objectives, clear and declination of these KPIs. A prospective tool for health that give me the way for public authorities. Let's celebrate investments and the risk-taking of health companies. Let's co-sign with public authorities and all the involved players a sort of manifest of health sovereignty in France and Europe. And let's do the health pride. Let's be proud. And let's recognize the pride we have.